Once again, a very good evening. So all settled. Welcome all the panelists. Can I have this on the screen? Okay. So we begin with our first case. I'll give you the background of the case and then we will start discussing. So this is the case of a 38-year-old male from Salabas village, which is near Jodhpur. He's a bank officer. On 2nd of January, this is last month, he was referred to a neurosurgeon at our hospital. And he was admitted in ICU, attended by his cousin brother, who doesn't stay with him. He was referred to us as he was found to be HIV reactive in the preoperative work. Now the history of presenting illness went like this. It was almost an acute illness as per the history given by the patient himself. On 29th of December, he had acute onset severe headache, which was mainly frontal, with multiple episodes of vomiting. The same night he had a seizure-like episode, for which he consulted a nearby hospital in his village and was given oral steroids and symptomatic treatment. He continued to have persistent nausea, headache, and then on 1st of Jan, he had severe headache with multiple episodes of vomiting. Probably he had some motor weakness and he was unable to stand on his own, and that is the time when he was admitted in Jodhpur. He was shifted from his village to Jodhpur and they did an MRI with contrast there, and it showed around 25 by 23 by 20 millimeters lobulated, heterogeneously enhancing abnormal signal vision with surrounding disproportionate edema involving the right gangliocapsular region and right corona radiata. Also, there was mass effect with effaced sulci, compressed right lateral ventricle and contralateral midline shift of 5 mm. And these are the other images if you are interested to look at these. Now this is the CBC which he came to us with. It is pretty much okay apart from thrombocytopenia. The platelets are reported 55,000 and HIV is reported non-reactive. And during hospitalization at Jodhpur, he received piperacillin, tazobactam, dexamethasone, anti-epileptics and mannitol, and then he was shifted to SIMS, that is the name of our hospital, to the neurosurgeon. Basically, he was shifted for brain biopsy. Now, when we examined him, the patient was conscious, and before I saw him, he had already received steroids and mannitol, so he was probably in a better shape, though he was a little bit confused still. General examination was okay. His vitals also were fine, and there was no neck rigidity, but he did have some weakness on his left side with a power of 4 by 5. Now, when we took the past history in detail from the patient only, he did not give consent to talk to any of his relatives, and his cousin brother we came to know later on, he didn't know anything about his HIV status. So this patient was diagnosed with HIV in 2016, and he had received ART from 2016 to 2020 from the ART center in Jodhpur, after which he had stopped it on his own, and he didn't come, of course, with any of those records. However, he did not have any history of opportunistic infections in the past. He did have some history of oral ulcerations 3 to 4 times in the last 1 year, which could probably be oral candidiasis. And there was history of significant weight loss, around 10 kgs in the last 1.5 years. He denied any significant fever, prolonged headache and constitutional symptoms, and repeatedly emphasized that all these symptoms have appeared acutely. And this is the CT which was done at our setup, CT brain with contrast, and as you can see, enhancing lesion in right basal gangliocapsular region with extensive surrounding perilesional edema is there. And there is a mass effect in form of pressure over right lateral ventricular system with a midline shift, as corroborating with the MRI. And here we found that he is HIV reactive. In our reports also, he did have mild thrombocytopenia, platelets around 90,000. So this is a 38-year-old male who is an ART defaulter with significant weight loss, right SOL with left hemiparesis and seizures. So I would like to ask one of our panelists, at this point of time, what would be your differentials and what should be our further workup for this patient? Dr. Nitesh, if you want to.
This is a case of PLHA, particularly is already ART defaulter. So absolutely, he is already defaulter since 2019. That indicate his CD4 should be very low, and his acute onset of seizure with new onset of focal neurological deficit and presence of mass within the basal ganglia. So they also with midline shift. That indicate possibility of infective etiology. It could be a toxoplasmosis because involvement of basal ganglia, as well as possibility of tuberculosis also. It could be even invasive fungal infection also. But perspective of total count are within normal range, but it might be possible that possibility of bacterial access. But MRI not purely suggestive of any considering access. What about CD4 count and viral load?
Yeah, I'll come to that later on. So let's discuss the differentials and the further workup, and then I'll show you all the reports. Sir, do you want to add anything in the differentials, or Dr. Trupti, do you want to add anything?
There are 4 things here. One is that you look at the clinical presentation. 2, you look at the risk factor, and the third one you would look at it is the speed of onset of this presenting complaint. All of this happened in the last 1 week. I am assuming that this was the patient took 1 week. In the last 1 week. So it suggests to me an acute presentation of a CNS problem. I teach that if you've got a focal seizure and you've got signs of raised intracranial tension, you've got a mass lesion or a space-occupying lesion. You are able to localize it because your left-sided hemiparesis is got a lesion on the right side, and you've got a good midline shift. Now, we just listened to the conversation earlier. Is it an infection, or let's say, is it an abscess? Second one, is it a malignant lesion? Third one, is it because of a let's say glioblastoma? That's a malignant lesion. And the third one is whether it is anything that is causing a demyelination. I am not great at understanding diffusion studies of the MRI or with the weighted scans, etc. All that I can say here is that there is a mass lesion. Now, because it's an HIV conference, and I'm assuming that this is an advanced stage of HIV because it is continued therapy, having been diagnosed over 9 years ago, the CD4 count is likely to be very low. I would be very hesitant to do a lumbar puncture simply because the platelet count is 90,000. So I have to go by the features what I see out here. So am I dealing with a fungal cryptococcus? Am I dealing with a tuberculoma? Am I dealing with an abscess due to a bacterial infection? And am I dealing with let's say a form of a malignancy or a demyelination? So it's very difficult.
Okay. You people have missed one differential.
I will choose abscess.
No. We just, Dr. Hemant just mentioned it, very close differential of toxo. Anybody? So you don't want to put PS primary CNS lymphoma in the differential?
He just said that.
Oh, sorry. I didn't. Okay. So if we look at the MRI and the CT, the enhancement of the lesion is actually not a complete enhancement, as Dr. Hemant Patel taught us just a while ago, that how you differentiate between an infective abscess and a malignancy is that you get a very solid enhancement when you have abscess or infection. On the other hand, if you have a malignant lesion, you would have patchy or nodular enhancement on the CT. So that is how we were thinking more on the side of malignancy at this point of time. And as per the workup we would send, CD4 count were 12 and HIV viral load was very high. DDRL and TPHA were negative. We also sent an LDH which was normal. USG abdomen was normal, and a CT scan which was actually done as a part of baseline investigation The patient did not have any respiratory symptoms at all. That also actually was a debatable thing. I could not perceive much. Even the pulmonologist also could not perceive much on the CT. But the radiologist was very sure that there are diffuse GGOs in both the lungs. And we believed him, and then we worked on that also later on. Now at this point of time, do we want to send any other investigation apart from what we have done?
With the low CD4, we would definitely send off a serum cryptococcal antigen.
Correct.
Even toxoplasma antibodies.
Absolutely.
And that would pretty much, there isn't an evidence of another TB elsewhere, at least on the scans that were seen.
Yes.
So before we go in for a invasive lumbar puncture, at least we should see both those non-invasive tests.
Okay. So absolutely correct. The anti-toxoplasma IgG is high. It is 94.1, which is quite high. We also did a beta D glucan. Yeah.
GGOs
GGOs are there.
Yeah.
So yeah. So awaiting the invasive test, we wanted to finish our non-invasive workup completely. And if we talk about the differentials of CNS lesions in HIV, we actually can divide them into space-occupying lesions and non-space occupying lesions. Now amongst the SOLs, we have toxoplasma encephalitis, primary CNS lymphoma, bacterial fungal brain abscesses and tuberculomas. Rarely even cryptococcomas, syphilitic gammas and neurocysticercosis can present an SOL, though they are not the typical presentations. And sometimes in the setting of iris, which occurs with increasing CD4 counts, even PML can present as an SOL. On the other hand, PML and HIV-associated encephalopathy are usually non-space occupying lesions. So if we look, when we discussed this with our radiologist, she just kept two differentials. One was toxoplasmosis. Her first differential was primary CNS lymphoma, mainly because of the atypical radiological features. And her second differential, which we actually emphasized on, was toxoplasma encephalitis. So now the next question is, what should we do first? A CSF examination, a brain biopsy, because that is what the patient has come to us for. He has come to the neurosurgeon for brain biopsy. Or we should do both. And should we rely on anti-toxoplasma IgG for the diagnosis and start him on treatment?
What I would do is start on treatment, because in toxoplasmosis, the treatment pretty much becomes the diagnosis. They start responding to treatment so quickly that while we are waiting to do invasive tests, we would have seen the response. So, and anyway, we would need, the beta-D glucan was high, we would need a Septran anyway. I would at this point start with anti-toxo treatment and then think of further examination, including CSF, but not brain biopsy. I would first go for CSF exam.
Okay. Sir, what is your take? Sir has already mentioned that he...
I wouldn't sell myself on an anti-toxoplasma IgG alone. I know that the GCS score is 14 or 15 because it's only a little confused. Now he's got a massive edema. Toxoplasmosis by itself doesn't produce such a massive edema, it produces multiple lesions. Now, CSF examination I would not do it particularly because of the restricted intention, and I am very fearful about coding and death. Brain biopsy is an option, but what am I biopsying him for? Tuberculosis, cryptococcosis, and autonomic abscesses, which are all eminently treatable. So I would go in for a brain aspiration and a biopsy.
Okay. So, Trupti, our radiologist was absolutely clear that this is not a typical toxoplasma, because there is no concentric sign which Dr. Heman showed. There was no hemorrhage at all, and they were all, it was a single big lesion. Toxoplasma also can present as single brain lesion, but they are usually multiple.
Listen to an excellent talk on this, because they're supposed to have some eccentric type of a lesion.
Absolutely, yes. So are we sure that we want to start toxoplasma treatment based on just anti-toxo IgG? So we did a CSF examination, consulting the neurologist, and if we could avoid the brain biopsy. However, it did not help us much. It was pretty much normal. CRAG was negative, toxoplasma PCR was negative, gene expert and cytology also turned out to be negative. So we are back to square one.
I anticipated that it would be normal.
Yeah.
Because then you are talking about encephalitis.
Absolutely.
Encephalitis
Yes.
is not going to cause any changes in the CSF.
Correct.
Number one, and it is worrying, it is dangerous. Please do do not ever do lumbar puncture in a patient who's got a spacer-defined lesion presenting with seizures and altered sensorium to that extent. But because you can manage it.
We could manage it, sir. And the neurologist was very confident that now he's stable enough
No,
to.
don't use the confidence of any neurologist. Are they gods? We know by status that you can't, it's dangerous. 9 out of 10 will have a problem.
Sure. So, if we talk about the CSF in toxoplasma encephalitis, the sensitivity of PCR, if we want to diagnose toxoplasma based on that, is just 50 to 98%. However, it is highly specific. How do we do definitive diagnosis of toxoplasma encephalitis? So, it is presence of a compatible clinical syndrome, identification of one or more mass lesions by brain imaging, and detection of organism in the biopsy specimen. However, most of the times, because biopsy is not a thing, which everybody does.
But Dr. Mathai, I think we have 2 more cases after this, so we'll have to wrap up.
So, the presumptive diagnosis is made by CD4 count less than 100 cells with a compatible clinical syndrome, a positive IgG, and a brain imaging, preferably MRI, with typical radiographic appearance, which we do not have here. Now, if these criteria are present, there is a 90% probability that the diagnosis is toxoplasma encephalitis. However, if a solitary CNS lesion is detected, even if IgG is positive, evaluation of CNS lymphoma should be performed. Again, if we talk about anti-toxo IgG, it has got a very high sensitivity to rule out, but it is not sufficient for diagnosis if other criteria are not met. So we did go for a brain biopsy, and we were lucky enough to see a brachyzoid of toxoplasma in the brain biopsy sample. Now, any other further workup? We went for the bronchoscopy in view of positive beta-glucan and diffuse GGOs, and PCP-PCR target was positive, and we sent the toxo-PCR as well, but as expected, it was negative. And as Dr. Trupti mentioned, serum cryptococcal antigen was done, which was negative. Fundus examination did not show any changes of toxo or CMV. Now, what about the treatment? So we have proven that this is toxoplasma encephalitis. It's a definitive diagnosis, and there is PCP. What should we start? What should be our line of treatment for this patient?
Actually, for toxoplasma, sulfadiazine, pyrimethamine, Vellore is the drug of choice. Particularly within 2 weeks, patient will get the response. Optimal duration is at least 6 weeks. But if you want to continue with you want to combine treatment of PCP also, then Vectrin is also a good choice. Particularly injectable Vectrin is available, so we can cover what the organism with the single antibiotics.
Correct. Any other inputs from the other panelists?
You focus on the brain lesion, or you want to focus on the lung lesion to save the life of this patient?
First of all, CNS lesion is more important.
Yeah. So we are worried about CNS more, but we are worried about both because we know that after starting treatment, there are chances of paradoxalitis. So the preferred regimen, the conventional treatment has been the combination of sulfadiazine plus pyrimethamine with leucovorin. However,
I'm very sorry, I'll have to give you last 1 minute.
yeah, this is the last slide. The treatment with otrimoxazole also, there is a lot of data now that it is as efficacious as the conventional regimen, and it has been as good as sulfadiazine pyrimethamine to prevent relapses as well. So we started this patient on otrimoxazole, initially injectable followed by oral. The dose we kept was for PCP, that is 15 mg per kg of trimethoprim per day, which is higher than actually the dose needed for toxoencephalitis. And when to initiate ART in these patients, that is basically within 2 weeks of treatment for toxo. Once the patient is tolerating therapy, of course you should be confident that there is no risk of iris and all. And then we, yesterday only this patient came for follow-up, and this is his yesterday's MRI brain, which shows complete resolution of the edema, and the lesion also has regressed in size, and we have put him on maintenance therapy now after 6 weeks of intensive course. Thank you.
So, in this case, I think I would have.
The patient on today's date? Do you have the follow-up of the patient on today's date? 22. This is 22 January.
Yesterday.
Which is 22 February.
They followed the patient up yesterday.
इसके पूरे टाइम मुझे थेरेप्यूटिक टेस्ट
Yeah, I know. I think you had the privilege of doing a biopsy, a brain biopsy. In this case, like I said, there isn't a harm of starting toxo treatment. No. So I'm saying that oftentimes like you're just starting the treatment within a few days would have
I
shown
totally agree with you. I am not against
No,
this.
I'm just saying that as a
So these are basically few options. And as I presented in the literature, because everybody was like, this is lymphoma, for sure this is lymphoma. And so we were a little skeptical. And of course, this patient was, the relative was like saying, brain biopsy कब करेंगे, brain biopsy कब करेंगे, हम तो उसी के लिए यहाँ पे आए हैं. So it was like that. But yeah, I totally agree with you. Response to therapy is itself a diagnosis in toxoplasma and cases like this.
Thank you so much. I would request the next two speakers to please. Dr. Surbi has requested your time. She's taken away some of your time. So if you could stick to your time. Dr. Hiran Ravina from Guntur.
So I think I got the agenda down. So I actually didn't make an interactive session, but madam has already taken up most of what I did. So I'll just go on with it. So my case is actually again another common scenario, 31-year-old unmarried male who had no previously known comorbidities, presented with mainly 1 week of history of low-grade fever, altered sensorium, and seizure on the day of presentation. So he was intubated in the emergency because he was having persistent low GCS only for the airway protection. So then neuroimaging was done, again Day-2 images which had shown multiple lesions with perilesional edema, some big with up to 3 to 4 centimeters, and contrast study was later advised. So in contrast we had ring enhancing lesions, some showing concentric ring enhancement. So further investigations was found to be reactive for HIV, and other blood investigations were remarkable. We asked for HIV RNA PCR 84 count, and also asked for a CSF analysis because he was not having much pressure symptoms other than low GCS at that time, and asked for serum toxoplasma serology and a cryptococcal antigen. So the brain SOL lesions, these are already been discussed. The broad differentials will be infections in which toxoplasma, cryptococcus, TB, PML, and CMV. Abscess, bacterial, fungal, sometimes parasitic even. Neoplasms, commonly primary CNS, sometimes metastatic lesions as well. And parasitic cysts like neurocysticercosis and other common as well that you see in the normal populations as well are possible. So in this patient, CSF analysis was largely unremarkable like previously, with only a mild elevated protein of 87. CSF, EBV, toxoplasma, JC virus, all the PCRs were all negative. The serum and CSF cryptococcal antigen was negative, ADA was 7.5, which I didn't order. The serum toxoplasma serology, again, IgG is positive. So at this point, again, the same question. So this is this toxoplasma encephalitis, and is biopsy required? So I just go forward and just to revise. So still the most common.
Just one question. You didn't do a gene expert.
No,
Really?
not common.
Why would you do a gene expert in this patient?
So the serum gene expert is likely low and very good. So the most common CNS infection in case of an advanced HIV disease is cryptococcosis, toxoplasmosis, tuberculosis, JC virus, and an EBV virus. So still, though toxoplasmosis is decreasing, so it is still the most common CNS infection to affect HIV.
Just one minute, back up there. Now, whenever we make a clinical diagnosis, is a clinical presentation, what does it feel like? Is it an acute onset?
Yes, it is an acute onset.
Okay. Is it rapidly progressive?
Yes, sir. Yes, sir.
So when you go to acutely onset and rapidly progressive, then you look at the risk factors, HIV and advanced HIV. Then you look at the epidemiology, which is the most common epidemiology here. Tuberculosis.
Tuberculosis.
You understand? So if it is tuberculosis, I will tell you this. Now this toxoplasmosis. I have tested my toxoplasma level. Pregnant women are getting their toxoplasma levels checked. When are you really going to check it? For anybody. Just because you have a pretest probability of this toxoplasma, we are checking it. Have you done it in normal 100 people? So when it's a disease state, we are beginning to do it. Okay, toxoplasmosis is a possibility. Tuberculosis is an equal possibility. JC may not, it's not an immediate killer. But so cryptococcosis can also exist. Yes. So how do I put my epidemiology?
As you said, most common is tuberculosis actually. If you are not considering the advanced HIV disease.
No, all three are probable. 1, 2, 3.
Probable, yes.
And all three are eminently treatable.
Yes. The first one being serum and case of cryptococcosis. TB we didn't do in this
You know,
patient.
the other important thing in those with low CD4 count is that diagnosing one opportunistic infection doesn't rule out the other. Sometimes it's possible to have more than one opportunistic infection coexist.
We have to look for all.
Yeah.
This is a case study, but you're seeing a patient eyeball to eyeball. You understand? And you got now, I don't know, because you got the multiple lesions, or you got cryptococcosis, or tuberculosis. My rank order would be tuberculosis, cryptococcosis, toxoplasma. Today I teach medical students the number one culpable pathogen that can be cultivated in the CSF is cryptococcus. Next is tuberculosis. You understand? So, we have to improve on our prevalence patterns to see, but I would shoot for tuberculosis.
So tuberculosis definitely is the close to them, but going with imaging, that is what I want to focus on. Imaging, finding if they are quite sure of one thing, that is like it was not done in this case, but as ma'am told, other OAs can definitely be present, and we should rule out for other OAs as well in any case of HIV. So I just wanted to give a general toxoplasmosis. So why to not rely on ICC? So almost 1/3 of the patients will have a positive IgG, and though it is still the most common, and if you see the zero prevalence in HIV patients slightly higher, recent study shows even 73%, but the global Indian data shows around 20 to 30%. So the challenge is in diagnosing toxoplasma in HIV. So reliance on serology test. So that is one main problem. IgG can sometimes be late also, but more than that, it is positive in most of the patients and may not indicate active disease. PCRs, though there are multiple targets, they are less sensitive, and the negative does not rule out the disease. So that is where I think imaging becomes more important when it comes to toxoplasmosis, because there are specific signs that are very highly useful for diagnosing toxoplasmosis, like concentration. So we already know this algorithm where we go for multiple lesions, where anti-toxoplasma serology, if it is positive, you empirically treat. Even if it is negative, they say to consider for brain biopsy early if there are multiple lesions. So when we are talking about imaging for toxoplasmosis, as Seman sir already pointed out, concentric the target sign and eccentric ring sign. So concentric target sign is seen in T2, eccentric ring sign is the post-contrast. So concentric target sign is actually a more important sign than an eccentric target sign, because it clearly correlates pathologically, demonstrating here the different zones that are present in a concentric ring that correlates with the toxoplasmosis. So the main characteristic important being T1 and T2 being hypointense in the central lesion that corresponds to hemorrhage in toxoplasmosis. So that is why I said to bring about the imaging part is a more important part when talking about toxoplasmosis. So next comes to the treatment. So important IV cortisone is what I prefer in this patient taking, and along with it adjunctive dexamethasone and levetiracetam. And work for other OAs. So syphilis, even tuberculosis. We actually didn't do a G expert, but we looked for tuberculosis elsewhere in the body. So what are the commonly used drugs when it comes to toxoplasma encephalitis? So in my experience, I have used only one drug till now, because pyrimethamine has been late to procure, or I was just afraid. So this has definitely changed in the recent times. But only thing is that studies were lacking. So this was published only last 2 years back in 23, where they showed meta-analysis of, though it is still an alternative regimen, it is definitely a safer regimen, and there are significantly lower discontinuation due to less toxicities. But ASICON is definitely are pending to decide that cotremoxazole is as effective, maybe even more effective than the pyrimethamine-based. So next is steroids, the indications mainly about the edema and the mass effect and significant iris syndrome. And more important, discontinue as soon as feasible, and the CNS lymphoma also, which initially responds to the corticosteroid. So that is one important differential when you are taking it. So initiating ART after this patient actually within 2 weeks improved, not 2 weeks, within the first week he improved, he was extubated, 2 weeks shifted to oral, corticosteroids were tapered off before, load was high, CD4 of 80, later the 6 weeks after the treatment with cotremoxazole. So we also talked about chronic maintenance therapy, because I want to talk more about this because I had one patient who was, after completing treatment of 6 weeks, was given a prophylactic dose of cotremoxazole, which is double strength 1 tablet only, and he relapsed just. So the usual chronic maintenance dose for cotremoxazole post secondary prophylaxis for toxoplasmosis is double strength twice daily. So this most of the times is being not properly followed. So we need to maintain that for at least when the CD4 is more than 200. Maybe then we can shift to 1 tablet only. So the take-home message will be for toxoplasmosis, though it is declining, still becomes more common. Diagnosis, serology, PCR, imaging, I think, should also be main part, which is usually not the part of our algorithm. And then when to biopsy, we decide based on it. Cotremoxazole, safer alternative, preventive chronic maintenance therapy is important. Thank you.
Do you do the torch in normal people, pregnant women? So are you relying on the torch? Are you treating patients on the torch report? Okay, number one, leave it aside. Number two is, I know that we have more cats than dogs as pets in this country. Is a banker, what is this exposure?
So we have more dogs than
cats. To toxoplasma. Because there with the West it's easier. Here we have as such. The third part is I rely more on IgM, not so much on IgG. Okay. And in a CNS case, because there are only three ways in which you can die. First one is coding. So I'm very, very nervous about the CNS lesion, and I will not rest on other probabilities other than direct visualization of the organism or pathology. That is why I will push myself for a biopsy. And it's easy because it's very surface lesion. We're doing so many of them. The second part of it is, in HIV, we just studied that you could have 2 organisms. How can we rest on your laurels by saying that it's only one organism, which is not so typical as such. So these are the concerns that we have when we practice medicine. But you're right, you've got a good diagnosis, patient has improved, and it's satisfactory as such.
Yes, so coming to the questions one by one, the torch profile. So IgG and IgM is what they do generally. The problem comes when they are doing for pregnancy, they don't do heredity test. So IgM can be late seroconversion to IgG, but the heredity testing is what usually is not done, and which is required when you are testing for pregnancy. Here, if you are relying on IgM in HIV patients, it is again a problem because in previous exposure, long back can reactivate when CD4 falls down. So here, IgG is more important in HIV patients.
IgG is long term, right?
Yes, sir. Long term can reactivate when HIV.
So you're saying it is reactivation?
Most of the times it is reactivation, like acute infection. So acute infection then present with lymphadenopathy, fever, and so. So most of the times it is reactivation in HIV.
Yeah, we believe it. Teaching it like that.
Yes.
Thank you.
Thank you so much.
Can I make one comment? Dr. Mathai, Just for historical reference, in the old days, when we didn't have HIV and all of that, in the United States, we would rely on the Sabin-Feldman dye reaction to demonstrate the presence of an immune response to toxo. And the reason IgG was found, in the early pre-heart days, if somebody was seropositive IgG, they had at least a 10 to 15% lifetime risk of developing toxoencephalitis, as opposed to those people who are IgG negative, their risk was less than 1%. So I think that's the beginning and the end of the utility of IgG for toxin. IgMs, as a general rule, IgMs are a very difficult test to do in the lab because they're unreliable. The only reliable way of looking at IgMs is actually to do complement fixation. It requires a very skilled person to figure out what is true immunofluorescence, what is background immunofluorescence. So anybody who's doing IgMs for anything, keep that fact in your mind that the ELISA run IgMs are inherently unreliable. So unless you show a big fourfold increase in IgMs, be very careful.
Now then, next session, Dr. Vipul Patel, he is a consultant IT physician practicing at Govt. He is going to present presentation on CNS reason, looking for solution in HIV. Thank you.
Because of the short time, the case having the first part I will go as early as possible. My topic is the CNS treatment looking for a solution in HIV case. Just recently on the part of 30 years of the village, came from the Gujarat. He was in 2017, presented with the fever, low-grade evening rise, loss of appetite, generalized weakness, dry coughing, and the weight loss 5 kg in 2 months. These are the complaints for the 20 days. So he has locally consulted physician, he has done the routine investigation, blood reports are normal. Action chest showing the patchy soft tissue obesity, and it is the diffuse infiltration. Multiple small nodular obesities are there, and both the lungs are involved. So radiology was mentioned, it is looked towards the tuberculosis, pulmonary consolidation. These are his X-rays. I will go with the further. He has consulted pulmonologist with 1 week down the line. Antibiotic was used but not improving. Further workup was done and it's turned out to be HIV positive. So pulmonologist done the HRCT for X. Look at that. Consolidation in the cavity of the peribronchial lesion, nodular multiple obesities, nodular cavities are the multiple site, and the multiple lymphadenopathy, but no necrotic lymphadenopathy. Radiologist has mentioned this is the pulmonary cause, and it will be secondary fungal infection like. So the pulmonologist was started empirical tuberculosis therapy. After these are these HRCT, look at this one that multiple nodular cavities lesion, multiple diffuse infiltration in the city. So he has after 15 days down the line consulted to me, and in presentation he is having the fever, low grade evening rise, dry coughing, no other system was involved, and on the physical examination vitals, temperature was 99.8, pulse, blood pressure, respiratory rate and SpO2s are absolute under control. No anemia, no icterus, no lymphadenopathy or no skin lesion. Respiratory system, bilateral cavitation, CVS, per abdomen, CNS are the normal. Further HIV workup was done out. CBC, LFT, RFT, electrolytes normal, TPHA, VDRL was negative, toxo-IgG was negative, the CD4 count was 72, HPSAG, HC is negative, cryptococcal antigen was negative. 2D was performed, it is normal, and sono was done, multiple soft tissue site. It is having that right cervical lymphadenopathy 1.3 centimeter, no necrosis, no palpable electron examination, and mediastinal lymph node 1.7 centimeters. So looking towards that particularly in this case, what is your differential diagnosis? Anybody will teach this particular?
Given a person with HIV and our setup TB for sure, in one of your scans there was peripheral smearing, and I would definitely keep PCP as the second Y in mind, given bilateral involvement. And the third would be a fungal.
Yeah, so this is the differential diagnosis also I kept it in sequentially. Tuberculosis, PCP and invasive mold infection. Other I will be ruled out with that and we will not discuss that particular part. So what will be your further investigation, whether lymph node biopsy or whether it is going for bronchoscopy, ball and biopsy?
Bronchoscopic, Gavard will give us both all the diagnosis.
Yeah, so we have underwent the bronchoscopy and ball examination. Look at the result. Electromanal was negative, no cyst of PCB, G-nex is negative, KOH having the sample, branch expanded fungi. Pyogenic culture are negative and fungal culture as per Dilip's levels. well after 42 days down the line, and biopsies suggest only focal infiltration of the lymphocyte and histiocytes. No fungal granulomas was identified. These are the images on that part Patritis. These are the Aspergillus flavus on microscopic image. How can it be very significant? Bulk electromagnetism is negative and then culture was positive. Do you think this is the invasive mode infection?
It could be a colonizer there. That's one possibility.
Okay. So looking towards the criteria whether it is probable invasive mode infection in the lungs in HIV host. Probable invasive mode? Yeah, we can have the probable invasive. It's not the proven, it's not having histopathological confirmation. So we have treated with the voriconazole standard dosage. EMP SMX was used as a prophylactic. Voriconazole was man-made. No side effect of the voriconazole. After 45 days down the line, the ARV was initiated. It is PDA, CAPRISA, and nabilepine extended release. 3 months down the line, X-ray, CT, and CD4 was repeated. CD4 was 278, and HRCT was absolutely good enough. Look at this. CT. So, probable invasive mode infection in that HIV component, we have treated with that. Do you have any comment on voriconazole or nabilepine?
Drug interaction.
Yeah. So, what do you think? What to do?
Now, this is 2017, I believe, so you are still using nevirapine, but right now you would have to use dolutegravir and then there's no drug interaction.
Okay, so the nevirapine is the inducing effect on the voriconazole. Voriconazole drug level will be reduced, or efficacy will be reduced, or effect will be reduced. So voriconazole, but the 1.5 months down the line, we have added the antiretroviral therapy. So little bit adjustment of the voriconazole was done out, and invasive mode infection we have treated for that 3 months down the line, patient was improved. So here on the consecutive follow-up, it not that the adherents are the good. Incomplete adherents, unscheduled visit in the OPD every time. He is not ready to change on the ART. He is continuous with the same ART. EMP SMX was continuous as a prophylactic, and the routine testing was normal. His consecutive CD4 study, if you see on the 2017 to 2021, it's not more than 200 plus. It is only around 178 max by max. And suddenly it will be with that ART defaulter returns in 2021 with the SJ syndrome and the viral involvement. At that time, viral load was 5,65,000 copies. HLA was done because we have to change the antiretroviral therapy. So HLA was negative. So ABC, TTC, and TTG was added. Epson was added as a mentioned because of the TMP of the navirapine and the SJ syndrome. And consecutive follow-up, his CD4 was maintaining good. Look at his consecutive study of the CD4. He is having maintaining CD4 more than 500 plus. Suddenly on 2022, he is having a left throbbing headache. CT was done, asymmetrical periventricular multifocal involvement. It is hypotensive involvement, and that frontotemporal and parietal as well as on the PML looking by that radiological finding, but no feeling for the MRI and CSF examination. Outside, he has started the steroid. He has tremendously responded with the same ART, good CD4, continuous management. Look at his CTs. After 1.5 months down the line of the CNS presentation, he is having the PDNS, GTCS and the fall down. At this particular moment, MRI was done. This time he is having the symmetrical presentation on the MRI. Multiple sites was involved, frontoparietal-temporal as well as some extension to the internal capsule, corpus callosum, brainstem, cerebri, radiologist finding out the PML. But looking towards that CD4 more than 500 plus, I will not convince this is PML at the moment. So CSF was examination partially done out. Lymphocyte predominant 30 cell, MPP is negative. JC virus DNA was negative. Routine test was normal. Serum viral load was done and it was undetectable CD4 552. Any comment from the panelists? What is going on? This is his MRI. It's a symmetrical now involvement. CT having that asymmetrical first.
Your confidence and to state that it is PML was fixed simply because the CD4 was high. So you ruled out all the infectious pathogens. Secondly, patient was on maintenance surplasma for some time. Yeah, so it is unlikely to be any of the toxoplasma. Now, he's a young person, so I don't really think in terms of vasculopathy. But at this stage, when he's doing well, and I don't think of an infectious lesion, and PML, there's nothing specific that we really need to do. We don't have to increase the dose of ART have better seizure management. There is no evidence of raised intracranial tension except that diseases that needs to be evaluated. Otherwise, I have no focal lesions.
So after 9 months down the line, another neurological presentation. At this particular moment came with the severe stroke. And the MR brain and angio was done. At this particular moment, he has consulted neurophysician. And it is having the PML likely to be the lesion was increased, radiologist mentioned. CD4 was 500 above. So treatment steroid was given, he has responded every time. And maintenance dose was ongoing, 5 milligram, cut down with the methylpred and then 5 milligram was ongoing. Look at his MRI brain. After 8 months of that therapies and as well as on that presentation. Another 2 months down the line, ongoing steroid therapy, he is having the backache and visual disturbances. So another neurological presentation where the spinal lesion was identified and it is D3 to D6 and D9 to D11. It is demyelinating lesion was there. And the radiologist, even if right now also mentioning this is likely to be the PML. Anybody else? Anybody else?
It could be a PML iris because obviously there was a rising in the CD4 count. Possibility of CV and encephalitis, there is a, it might be possible. We need to check the CD8 count also. Okay. And particularly CV and encephalitis is particular diagnosis with the biopsy only. Okay. Clinically, many patients are responding with the steroids.
It's been so responsive to steroid every time. It also makes me think we should rule out an autoimmune cause with a good CD4
Can
count.
go with this. These are the spinal lesions where the demyelinations are there. If it is PML iris, I don't think so. Spinal lesion was there. It's the brain iris majority of time present. Spinal is there to be in the PML. So these are the 4 different presentations. Yes. Okay. So
Did you change the ART before this? No.
coming to that point.
It was an anatomy based.
Two times he has presented to the neurophysician, ID consultant now coming in picture. So here the CSF examination done by the neurophysician, extensive workup was done. Because total count was 80, lymphocytic predominant, protein elevated, glucose elevated, gene axis negative, JC viral again done, it was negative, TPH negative, Indian cryptococcal antigen and crack was negative in CSF, extensive workup for the viral was done out, biofire negative. He has done for the demyelinating lesion for the neural part, negative. Vasculitic workup was done out, negative. CSF viral load, 2008. Plasma viral load, 218. Any comment?
Monoclonal, oligoclonal bands negative.
Yes.
Now you can get as a result of, you can contribute 85% of the times it is positive, another 15% of the times it may not be positive. So it could still be part of the neuromyelitis optica syndrome.
Okay. So,
Also moving to a regimen with the better CP score.
yeah, CP score is the major important when your viral escapes like presentation here.
So instead of Avacavir, if you could shift to Zidovudine.
Yeah, we'll go with that. Differential diagnosis like at this particular moment, retroviral with the viral escapes, one of the possibilities. Another is that differentiated with that HIV encephalopathy or myelopathy, which is such a CD4 never to be possible. PML, CNS involvement, the spinal involvement cannot be possible. Demyelinating disorder of the neurological part, antibodies are negative, hence do not have the sensory motor or severe stroke-like presentation. So any other cause? These are the differential from that MRI finding. Here, neurophysician was started, another immunosuppression, MMR with the steroid. Because every time ESD on the steroid responded, but this time will not responded with that. So the MMF was added, same ART was continued. After 4 months, another episode was the neurological, this time predominantly visual disturbance. But he did not have any orbital, spinal lesion was gone with the MMF. Neurological on the brain, same lesion was persistent in that white matter. So these MRIs, this is the spinal MRIs.
You tried pulse therapy with cyclophosphamide?
No, it was not tried.
Then what is the pulse therapy?
For the methylprednisolone. Methylprednisolone, 5 days followed by the oral steroid.
Okay. Plasmapheresis was considered?
No, no considered at that moment. So here what the extensive other workup we can do. Plasma viral load this time 695, serum the CD4 367, serum viral load, CSF viral load was 410, it was earlier 2000, now it is 4000. CSF flow cytometry was fully done, CD8 160, CD4 13, ratio of CD8 versus CD4 12:1, and the HIV resistant testing viral escapes are there, so it was advised from serum as well as CSF. But because of the not detectable viral load as a proper, it should not be performed. So what will be the final diagnosis?
The plasma viral load of 695 at this point is worrying me because by now it's several months into on treatment. So I'm also worried about the adherence of the patient for the ART.
2021 after that adherence was very good. Prior to that adherence are poor. Patients on abacavir, 3TC and dolutegravir.
Myelopathy, are you talking about bacterial myelopathy or you're just talking about the increased myelin changes that you're seeing on the MRI?
It's a both way. If you are viral as well as
paraparesis?
no, you do not have the paraparesis.
Okay.
Only ataxia presentation.
It's only the imaging that is telling us this. But is he able to walk and all?
Yeah, he is able to walk.
So
They
that
do not have that kind of the paraparesis or paraparesis presence. So looking towards that flow cytometry in CSF, what you suspect? Mitesh?
I wouldn't do anything further.
Okay, so you have to continue same ART.
My viral load is down.
No, viral load CSF rising.
CSF, I have no experience with trying to make the CSF viral load zero. And as we just heard, the CSF viral load, because there may be pharmacological sanctuaries, and my drugs may not get into that area.
Okay, so CNS having the so many anatomical compartment and CSF is the one of them.
Yeah.
So we can't have to be changed. Certain cases are having the same ART continuation, improvement, like in hand, definitely it is improved.
Yeah.
Certainly one. So here we have put on the relapsing celiac enterocolitis. I go to the literature and what actually thinking on MRI as well as on the part of flow cytometry, how it will be helping. So MRI having the punctured linear perivascular nature, it is looked towards the white matter lesion. CD8 and CD4 ratio 5.5:1 greater, it is celiac enterocolitis.
That's very good thinking. I didn't think in that line.
Yeah.
Good.
So here the genotyping testing was not able to do it, but we have to change the antiretroviral therapy to get that whatever the penetration we get in that lesion. So we have changed the ART. TTC, TTG and darunavir. Same immunosuppressions are ongoing. MMF was 500 milligram 1 PD. Looking towards the just 10 days back MRI was done after 3 months of the new ART. Same finding in that CNS. What we can do offer to the patients? Whether same continuation or we can do anything else.
Has the patient clinically improved?
Yeah, every time steroid given 5 days, patient improved.
I'm sorry to interrupt, we have to wind up this in the next 2 or 3 minutes.
Yeah.
In a patient who has an existing immunosuppressive condition, I would not have the guts to put him on a good dose of 500 milligrams twice a day and
Okay.
cause further suppression. Can you just what about the CD4 after that? Did it come down?
No, it's not done right now because 10 days back the MRI was done and then 3 months of the ART was just finished. So in a further consecutively follow-up we will do the CD4, even CSF examination we will done. I have skipped that particularly MFF immune suppression was aggravated or it is 1000 milligram per BD dosage, but patient has the side effect to not tolerate MFF. So the BD was continued by 0 PGC.
What about the CSF again? Repeat CSF also
So not done right now, we are doing that because 10 days back patient came for that. At that time we have done the MRI. So I gone to the literature of the celiac enterocolitis. It is having that poorly understanding of the HIV associated neurological syndrome. Most important pathophysiology is that auto-reactivation of the celiac cell. And it will be involved the attack towards the HIV CD4 and it will be mimicking towards the escapes. Viral escapes is the one of the triggering factor for celiac enterocolitis. We will definitely diagnosis by that biopsy is the answer, but it is very difficult to be performed at this particular moment. So that these 4 things, remember, kept in the mind: viral escapes, iris, another viral infection, and then ART default. These are the 4 triggering factors for celiac encephalitis. Viral escapes and repeated viral resistance patterns should be observed to management properly or changing of the antiretroviral therapy. These are the clinical presentation. I will not go into the depth. But here, there is no defining or maintenance dose of the steroid and how long you have to go with the steroid. But our target should be immunosuppression, others should be given rather than reliability on the steroid. So the MMF was the under answer, and the why MMF was selected by the neuro as well as our side, because 5 point is the main important. It is having the additive antiretroviral therapy benefits. It is having the maximum CSF penetration compared to other. It is having the side effects are the less, drug-drug interactions are the lesser one. So despite of the giving the steroid and MMF, patient's CD4 count in CSF 1 or 2 times it was higher one. Our target plan to be having the both immunosuppression will be reduced as well as on the maintenance part and then going to the ART of the same. So the learning point, these 5 points I have made it over here. If you are having that HI patients, diffuse white matter lesion, go for the CSF flow cytometry and CSF examination. These 4 trigger factors kept in mind. Steroid early to be started can prevent the morbidity and mortality. Look for viral escapes as well as the resistance pattern, and further alternative evidence for the alternate steroid sparing agent should be required.
We could do viral resistant test from the CSF also. Because
I have advised, but it was not possible. Even in 4,000 series, the viral load,
Yeah.
4,000 viral load. I have mentioned both them. Serum 695, second times. It's not possible. Even in CSF, I didn't know that what is the cutoff they are using because we have the genotyping only available. If it is on the sequencing pattern, these are the we can do in the future also. It is a little bit high costing. Management are the same.
Excellent, very well managed. You have taken some skill.
Thank you very much for this very interesting session. I would request our chairpersons to kindly hand over a token of appreciation to the speakers of this session, Dr. Ravela and Dr. Vipul Patel. Dr. Nirayan is here. I would also request Dr. Trupti and Dr. Dilip Mathai to hand over a token of appreciation to Dr. Mitesh Sundar.